A 70-year-old woman with long-standing hypertension and osteoarthritis comes to the clinic because of new fatigue and decreased urine output over the past 2 days. She says that she's been taking an over-the-counter pain reliever 3 times daily for knee pain. Her medications include lisinopril and hydrochlorothiazide. On physical examination, blood pressure is 138 over 78 millimeters mercury and pulse is 72 per minute. Laboratory studies show BUN 58 milligrams per deciliter 7 to 18, serum creatinine 3.6 milligrams per deciliter 0.6 to 1.2 versus a baseline of 1.0 milligrams per deciliter 2 weeks ago. Potassium is 5.4 milliequivalent per liter, normal range 3.5 to 5. Urinalysis shows no protein, blood, or CAS. Which of the following is the most likely explanation for this patient's laboratory abnormalities? Choice A, infiltration by white blood cells into renal interstitium. Choice B, toxic injury to hepatocytes. Choice C, inhibition of afferent arteriolar dilation. Choice D, denudation of tubular cells with loss of brush border and sloughing of cells. Or choice E, effacement of foot process of podocytes. I'll wait 5 seconds and answer the question. This should be very straightforward. This patient has an AKI, very likely caused by NSAID usage. And because the urinalysis is mostly unremarkable, we would probably assume this is more likely a prerenal azotemia and largely caused by the effects of the drug affecting GFR, which in NSAID's case, obviously, it's choice C, inhibition of afferent arteriolar dilation. Very basic physiology / pharmacology of NSAIDs. You have to know that prostaglandins cause afferent arteriolar dilation. And obviously, NSAIDs block that pathway, so I have less prostaglandins to dilate the afferent arteriole. Now, obviously, there's a couple other things you can take away from the question here. Well, first of all, this patient has long-standing hypertension, and she was already taking an ACE inhibitor. When you are taking an ACE inhibitor, you are affecting, obviously, angiotensin II, which is used to constrict the efferent arteriole. So when you take both, that causes a quote-unquote double hit to glomerular perfusion. You both can't dilate the afferent arteriole because you don't have prostaglandins to dilate, and you also can't constrict the efferent arteriole because you don't have angiotensin II to constrict it anymore. So your GFR is at a high risk of dropping, which in this case cost this patient's elevated BUN creatinine. Now, a couple of you might be very astute and point out here that how can this be prerenal azotemia if her BUN creatinine ratio is not 20 to 1? And my response to that would basically be very careful about dogmatically declaring that prerenal azotemia has to have a 20 to 1 BUN creatinine ratio. It's a helpful thing to help you diagnose prerenal azotemia sometimes, but sometimes that's just not the case. And even beyond that, you can pretty easily eliminate a lot of the other answer choices here. So let's take a look. Choice A, infiltration by white blood cells into renal interstitium. This is referring to acute interstitial nephritis, which, yes, can also be caused by NSAIDs. But this is basically an allergic reaction of the kidney. So this often presents with a rash, a fever, eosinophilia, and urinalysis would have white blood cells a lot of the time. And this patient has an unremarkable urinalysis, so it just doesn't really fit. Choice B, toxic injury to hepatocytes, is kind of a distractor. I mean, of course I was vague with the painkiller medication, and maybe some of you assumed that it might have been acetaminophen. But even if we assume that, it doesn't really make sense because she has no symptoms of acute hepatic failure, she has no jaundice, she has no elevated liver enzymes, so there's no reason to assume this. Choice D, denudation of tubular cells with loss of brush border and sloughing of cells. This is referring to acute tubular necrosis, which, once again, this is caused by ischemic injury, which, yes, can also be caused by NSAIDs. Acute tubular necrosis is pretty high yield itself. Obviously, you need to know that the proximal convoluted tubule is very susceptible to ischemic injury because it has a very high concentration of sodium, potassium, ATPases. So obviously, if I need a bunch of energy from ATP, if you are more susceptible to hypoxic injury. So they really like giving acute tubular necrosis in patients of, for example, hypovolemic shock, right? So they were bleeding out, they were stabilized, and then a couple days later, they have elevated BUN creatinine and they have muddy brown CAS in the urine. That's just acute tubular necrosis, right? Because they had hypoxic injury to the kidney. And of course, like I just said, ATN has muddy brown CAS in the urine a lot of time. And once again, this patient has a mostly unremarkable urinalysis. Choice C, effacement of foot processes of podocytes. This is a distractor. This is obviously referring to minimal chains disease. Again, pretty high yield condition, I think. This is a nephrotic syndrome that can't be observed under the microscope. You have to use an electron microscope to see it, and you'll see effacement of the Fook process of the podocytes. This is classically found in children. Most common cause of nephrotic syndrome in children. It can also happen in adults and the elderly, but they usually have some kind of predisposing factor to it, such as lymphoma. But really, all you need to cross this off is to know that minimal change disease is a nephrotic syndrome, and this patient, once again, normal urinalysis for the most part. So just to review, you got to know how prostaglandins work. You got to know how NSAIDs work. You need to know that entire arachidonic acid pathway. It's very basic stuff, and you need to know that prostaglandins dilate the afferent arteriole. I hope you found this video helpful. I'll see you in the next one.